Zuba Udasinek. It is a great pleasure to be here and to discuss what I hope you will find will be a very interesting topic. We'll focus on the issues of diabetes and vascular disease, but I'm going to link all three issues together, the blood pressure, the cholesterol, and the glucose, because you cannot separate them, and they all work together to lead to progressive vascular disease. I will touch on some issues related to the epidemiology and diagnosis, but really focus on the complications, the goals, and the clinical perspective. In the US, it is a sizable proportion of patients, and it's growing, and I am sure it is no different here in Sri Lanka, where it's a combination of genes and the environment which leads to substantial rates of diabetes, a lot more than we appreciate right now. And I think it's important for all of us to remember that there are important changes in glucose tolerance over time. As you can see here, with increasing age, there is a progressive rise in the fasting glucose, so that we travel from impaired fasting glucose to impaired glucose tolerance all the way out here to diabetes. But the thing we must remember is that vascular disease is occurring very early on before the actual diagnosis. And that, I think, is the very sobering concern, because we know there are both microvascular and macrovascular complications which lead to disability and death very early on. Some of these include neuropathy, and I will not belabor the point. Again, occurring early, sometimes even before the actual diagnosis of diabetes. We have retinopathy, which also occurs, an important concern. And of course, chronic kidney disease, probably representing 50% of all the cases that we see in the US, and I am sure it is very similar here. Again, it's important to remember that the early observations of low levels of microalbumin in the urine are a very important and early piece of evidence illustrating increased risk for stroke and heart attack. One must remember that only the lucky few live long enough to develop the kidney problems. Many, if not most of the patients, are developing heart attacks and strokes early on, long before they develop the renal failure. We tend to recognize the macrovascular complications as being more serious, but in reality, the microvascular complications leading to the kidney disease, the retinopathy, the neuropathy, can be of very important morbid consequences in clinical practice. But remember, it's the big three, the blood pressure, the cholesterol, and the glucose, which together increase the risk. And you have to imagine that it's like the ticking clock, an elevated risk of cardiovascular disease even prior to the clinical diagnosis of type 2 diabetes. And if I leave you with one message today, it's this issue. Look at the relative risk of cardiovascular disease in 117,000 women followed for 20 years in the Nurses' Health Study. Appreciate non-diabetic, and then obviously the almost tripling of cardiovascular disease prior to the diagnosis. After the diagnosis, and obviously this is what it looks like with people at the baseline. So this is an important concern to screen and look for cardiovascular disease, even in people with impaired fasting glucose. And of course, the greatest risk of all is when you add diabetes with even mild reductions in glomerular filtration rate. CKD being defined here as an estimated GFR below 60. Appreciate that the hazard ratio for vascular outcomes in people with and without diabetes is substantially different. What we're looking at here from the risk factors collaboration evaluation is really a twofold increased risk, which is even more magnified when you add the kidney disease to it. So it's important, again, to look at the clinical spectrum. Deteriorating fasting plasma glucoses, postprandial glucoses, and hemoglobin A1C, often associated with declining beta cell function, increasing body weight, escalating the need for treatments that increase the risk for hypoglycemia and body weight, and here I mean insulin, right? And then with that, the worsening risk of stroke, heart attack, and microvascular events. So if you look at the big picture, we're not talking about a binary disease process where you either have it or you don't. We're talking about a spectrum of disease that starts early and is progressive and leads to cardiovascular events. We need to start early and provide global cardiovascular risk reduction efforts in these patients, focusing not just on the glucose, but also more intensive strategies for the blood pressure and LDL reduction. Because these are people who are developing disease early on, long before you see the glycemic abnormalities. The whole purpose of the focus on blood pressure, cholesterol, and glucose is this strategy to delay vascular disease, both large and small vessels. Again, the big three. If you can just think about these big three, this is the critical factor. Again, early and aggressive management being the most helpful for delaying progression of vascular disease. So what I think most people underappreciate is the bottom part of the iceberg in clinical practice, which is undiagnosed type 2 diabetes. Appreciate the risk of stroke in people who are undiagnosed and people with prediabetes. Look how substantial this is. Coronary bypass, again, acute coronary syndromes. Substantial risk, even in people with undiagnosed disease. It's remarkable if you look at the data. But it really forces us to examine with the big three, how early should you start to modify the risk and how low should you go? And examining all of the different strategies we have in hand to make a difference. The toughest part's probably the glucose, let's agree. We have many good antihypertensive medicines. We have excellent statins. We have data now that ezetimibe can improve upon statin benefits and reduce cardiovascular events. But the glucose story is problematic. Again, the issues of insulin, appropriate, but how often necessary? Again, you have the weight gain associated with it, an important concern, and also the risk of hypoglycemia. There are many new agents being developed in diabetes, and I'll speak more about them a little bit later. But we have to weigh the pros and cons of more intensive glycemic management against, obviously, each individual patient's responses. But it's studies like these that make you wonder whether or not earlier management will make a difference. Look at the mortality hazard here. Green, obviously the worst, diagnosed diabetes. Contrast that here, normal glucose tolerance. But look at the progressive changes associated with impaired glucose tolerance and undiagnosed diabetes being as bad as diagnosed diabetes. So how do we best treat these people? probably we need to start a lot earlier than we have previously imagined. And I'll talk a little bit more about what are the best options in this regard. But I think we must remember, if you look at the data, there is a linear and progressive association between glycated hemoglobin and obviously risk for type 2 diabetes and cardiovascular disease. All right, important consideration. And we have evidence from the Diabetes Control and Complications trial that more intensive control of glycemia in people with type 1 diabetes provides a very important advantage. For every 1% decrease in A1C, a 35% reduction in microvascular disease, and a substantial 42 to 57% reduction in risk of cardiovascular events. In the United Kingdom prospective diabetes studies, 10 years of follow-up, basically a 1% difference between intensive and conventional. Look at the risk reduction opportunities. It's important to realize, as you look at the data, though, that microvascular disease, you can see the benefits within 5 years. If you're looking at macrovascular disease, it takes 10 years. 10 years. Which is why some of the studies you've heard about, which are only 4 to 5 years long, have not shown macrovascular benefits. It takes the longer follow-up. And of course, we have the epidemiology to support the fact that worsening glycemic control is associated with macrovascular events, and you can see the data here from UKPDS. Again, a 14% decrease per 1% reduction, 16% decrease per 1% reduction, and again, you're looking over 10 years. So appreciate we do have an opportunity here. The conundrum in clinical practice is how low do you go in each and every patient, appreciating the risks for hypoglycemia, because you can make remarkable contributions to a patient's survivability with this disease with more intensive glycemic control. Many of us were fooled by the data from the ACCORD study, which was less than 5 years. However, there were important signals that there may be some opportunity when you compare and contrasted the observations. We had the same data with the blood pressure, but remember, you need a 10-year study to see global events. And that's why we need to look very carefully at both ACCORD and ADVANCE and realize that although being short-term, we need to be careful in interpreting the results. In ACCORD, more potential risk for harm than good, but in ADVANCE, similar study, a little bit larger, again, you can see, appreciate reduction in renal complications. But the real opportunity are 10-year studies for macrovascular events. What you're starting to see at the end of 6 years is the advantage of intensive over standard in both of these studies. But now with longer-term data, we realize that these two lines separate substantially in the next 5 years. So definitely, intensive glycemic control does help. And what's even more interesting is there is a legacy effect of benefit which carries forward. And this, I think, is the most interesting aspect of it all. You will recall in the DCCT trial, they did a 10-year study of intensive versus conventional, and then they took them off the study and encouraged intensive treatment for everybody. And of course, the lines narrowed, all right, over the next many years. What I'm going to show you in a minute is that the people in the intensive group here, despite this normalization here, still derived macrovascular benefit. And that, I think, is the most important point. There is a legacy of benefit. And appreciate, too, the hypoglycemic events. Sure, they are higher, but we've got newer and better drugs today to limit the risk of hypoglycemia, and we have established opportunity to provide risk reduction benefits. So I think we have to appreciate that definitely getting the hemoglobin A1C below 7 is critical, and there may be opportunity in even going lower to 6.5 or even 6 if it can be done in a safe manner in individual patients. And my guess is this will require less intensive use of insulin and sulfonylureas and more focus on some of the newer strategies to intensify glycemic control, which are less likely to be associated with hypoglycemia. And here I'm speaking about many of the newer drugs like GLP-1 agonists, the SGLT2 inhibitors, which are well studied now and obviously reaching clinical practice. The biggest problem for you and me is that there is a greater cost associated with them. But we do have important opportunity here for intensification of glycemic control. And I think it's critical for us to realize when you start to look at data like this, and this is the extension of the DCCT and EDIC study, clearly showing you that those people randomized to the intensive care had that benefit continue forward past the 10-year mark, 15-year mark, illustrating this legacy of better treatment carrying forward despite very similar hemoglobin A1Cs. I think, again, if there's any message I leave you with today, it's this one. That's why longer studies are definitely needed to look at strategies for earlier intervention. Intensive glycemic control does make a difference, whether you're looking for non-fatal MI or coronary disease. Dramatic impact. No effect on stroke or all-cause mortality in this particular analysis, in large part because of blood pressure differences. But I think the critical factor is, if you look at the long-term data, as I illustrate here from the DCCT and EDIC studies, whether you're looking at heart, brain, kidney, they all derive benefit. And I think the critical point down here, 29 people receiving intensive diabetes therapy over 6.5 years will prevent 1 case of renal failure over a period of 20 years. A definite, important opportunity in clinical practice. Look at the differences here from the DCCT and EDIC study in terms of risk for impaired GFR. Again, just like what I showed you for cardiovascular events. So obviously, the guidelines are changing substantially in response to these extended clinical trial data coming out now. And certainly you can see that there is important effort to get everybody below 7. For selected patients, more opportunity, even lower goals, especially if they've had a shorter duration of diabetes, a long life expectancy, and no clinically evident cardiovascular disease. Perhaps less stringent goals in people who have problems with severe hypoglycemia, limited life expectancy, or more advanced vascular disease. So we have a number of unmet needs. I think the first and foremost is cardiovascular risk reduction. And obviously asking, is there a specific hypoglycemic agent that we can use for diabetes, which may reduce CVD risk over and above what can be done with glucose lowering itself? There are many more conversations about beta cell preservation and more comments specifically with whether any of the newer types of drugs may make a difference in that regard. And of course, the opportunity with weight reduction. One of the interesting aspects of the GLP-1 receptor agonists, as well as now with the SGLT2 inhibitors, is the weight loss and whether or not we can spare insulin and focus more on these drugs, which tend to diminish appetite or facilitate glycosuria to lose weight. They may even serve in the future as anti-obesity drugs. But again, it's the therapeutic index. It's the ratio of the benefit to the risk and adverse events, which is most important to us all. So going back to some of my key points, blood pressure, cholesterol, and glucose. If you look in diabetics, there is clear advantage of more intensive blood pressure lowering on both micro and macrovascular complications. And this is looking at a 10 millimeter difference here. And I think we would all agree now that there may be much greater opportunity going lower than that. In the US, we have the very large SPRINT trial. This is a study of 9,200 people, average age in their 70s, being treated to either 140 or 120. I'm on the Data Safety and Monitoring Board. I can tell you the study is still ongoing. So there is not a safety concern for lowering blood pressure to 120 that has been demonstrated. And stay tuned, because later this year we're going to be examining the data to hopefully make some decisions as to whether to continue the clinical trial or not. But I do think it's important to look very carefully at the blood pressure story. This is the data from ACCORD. And in the ACCORD study, again, it was a short study, I already talked about that, you will see the blood pressure was already very well controlled. Obviously, they had good kidney function. And it's not a surprise that if you have people who are well controlled with their blood pressure, with good kidney function, many of them receiving renin-angiotensin system blocking drugs and statins, that you don't have a risk of increased benefit, or I should say, you don't have a demonstrated benefit of 120 versus 140. But again, short-term study, many of the other ones now are much longer. Appreciate with diabetic kidney disease, we still lack a lot of data in terms of what are optimal blood pressure goals. I think the SPRINT study will help us. We also don't have any prospective clinical trials to examine purposeful proteinuria reduction as having a demonstrated benefit, although we do have secondary analyses illustrating if the proteinuria goes down during the course of treatment, that they do benefit. But of course, we do have the studies with the angiotensin receptor blockers, clearly showing important risk reduction benefit in this particular regard. But whether we should go lower than 140 will be hopefully seen in the SPRINT study. So I think it's fair to say in diabetics, we should be using renin-angiotensin system blockers. We probably do need lower blood pressure goals simply because we can see evidence of less risk for microalbuminuria progression, but we need more studies still. But I think this is the critical message as part of your global strategy in people with diabetes and vascular disease. And likewise, LDL cholesterol lowering, unquestionably making a difference. The heart protection study was published nearly a decade ago, but it's only been in the past few years that the NCEP adult treatment guidelines were changed to basically state that we should be abandoning threshold-based treatment and focusing on at least a 40% reduction in LDL from baseline in people with diabetes, which is exactly what all of these studies have shown in terms of reducing cardiovascular risk. Basically, if you have diabetes, you need intensive treatment with a statin, regardless of your baseline LDL cholesterol. Likewise, if you have chronic kidney disease, you need intensive treatment of your LDL cholesterol. The SHARP study clearly demonstrated that benefit. So both diabetes and chronic kidney disease need intensive LDL management, at least a 40% reduction from baseline. And this is a quote I actually wrote in a review more than a decade ago, focusing on the SHARP data, on the SHARP study before the study was completed. Basically making the argument that we should avoid threshold-based treatments and focus on that 40% reduction from baseline. And now finally, they have changed it. So going back to the diabetes, I think the cardiovascular risk reduction, the beta cell preservation, the weight reduction, all are a part of the story. I've touched on this before. I want you to remember the issues related to blood pressure and LDL cholesterol as well. I think the focus on the horizon will be obviously the newer agents for treating diabetes. There has been substantial progress just in the last few years. Take a look at the list, and we still don't have them all on there. There are many more coming as we speak. So there are opportunities. And to summarize, global multifactorial intervention is the critical strategy. We do have the benefits that have been shown for intensive therapy of blood pressure, cholesterol, and glucose, making a difference. And let me also say, too, any opportunity to improve behavioral modification as well, coupled with cessation of smoking and appropriate treatments accordingly. But multifactorial intervention does make a difference. You can lower glycated hemoglobin, you can reduce cholesterol, you can reduce LDL triglycerides, and obviously the long-term outcome is a 20% absolute risk reduction, which was demonstrated in the STENO-2 study in people with type 2 diabetes. So it can be done. We should be encouraged and should take note of this. So I think it's important to realize we have many new treatment strategies on the horizon. We need to become more knowledgeable about them. We still need to individualize the therapy for each and every patient, and hopefully in so doing, we will make a difference in terms of how to improve overall management. Individualized care is really the critical strategy, and ultimately providing better longevity and eliminating risk for cardiovascular events. I'll finish there. I would be more than glad to entertain any comments or questions. Estudi.